Hi, good afternoon, everyone. So please feel free to continue getting your lunch, which has sort of a Thanksgiving quality to it. Thanks to Sarah Faye for arranging a different kind of meal today for us from across the street. So welcome, everyone, to the Friday Innovative Discoveries and Excel talk. And as we try to do, we're going to challenge your thinking with some new ideas, and we span the gamut from biomedical to health policy, and today's one of the more health policy directed talks. Before I introduce today's talk, I wanted to give you two reminders. One is for those of you who require continuing medical education credit, hopefully you've signed up with the Christiana Care CME phone number, which is 543-2570. That is 543-2570. You have to register the first time. This time, if you've already registered, you send a text to that number, and text the number 218. 218 is the number for this talk, and that's also on the papers in the back. The second is that next week, Dr. Bill Weintraub, who's principal investigator for the Excel program here at Christiana, is going to speak about big data and clinical effectiveness, if I remember correctly, Bill. And that'll be same bat time, same bat channel, 12 o'clock next Friday. Today's talk is really exciting. We're going to be talking about health policy at the ground level, the impact of marketplace guides, who are now called health guides, on healthcare utilization. The speaker is Deanne Gaffney. She comes to us from Johns Hopkins University from the School of Public Health, where she is a doctoral candidate. Deanne has a great deal of experience in the area, having been an administrator at Johns Hopkins Medicine for the last several years. Our connection to Deanne was actually through her husband, Dr. Chris Prater, who finished his MedPeds residency here and was a leader in the global health program before he went down to practice in Baltimore. Deanne's work is part of her doctoral thesis at Johns Hopkins, and she is the first person to really take a rigorous analytical look at the impact of our Marketplace Guide program, which you'll hear more about, which is part of the Affordable Care Act. And in this role, she is mentored by Dr. Brian Raymer, Kathy Canatelli, and myself. I also am privileged to serve on Diane's thesis committee at Hopkins, so we've kept in touch over the years, and I think this will be really exciting for you to see how health policy works at the ground level. Please join me in welcoming Deanne Gaffney.
Good afternoon, everyone. Thank you for having me. I have no disclosures for this talk, and I'd like to acknowledge all the people that Omar just mentioned that have made this project possible here. Omar for actually proposing the idea to me, Brian and Kathy for being such great collaborators and helping me to think through the data. And then at Hopkins, the thesis committee is comprised of Daryl Gaskin, who is the director for the Center of Health Disparity Solutions, Doug Huff, who is a health economist, Marie Diener West, who is an epidemiologist and biostatistician, and of course Omar. And the funding for the MPG project, I'd like to also acknowledge, because that's also made this project possible, is from an IDEA grant from the National Institute of General Medical Sciences and the NIH, and with also generous support from the state of Delaware, UD, Christiana, Nemours, and the Medical University of South Carolina. So today, I hope that after this talk, you'll have more perspective on the ACA and its projected impact in Delaware, some insight into how a community outreach program and the data warehouse was used to assess the program's impact on patient care and resource utilization within the network, and have some ideas about statistical modeling approaches to explore utilization trends over time and between patient groups. So I'm going to be going through the ACA and the projected impact locally, the project framework and literature review, the MPG program here at Christiana, the data sources that we used, our modeling approaches, and some initial statistics, and then discuss some next steps and hopefully get some ideas from you as to how to proceed as well. So the Patient Protection and Affordable Care Act, in future I'll keep referencing it as the ACA, passed in 2010. The goal really was to reduce the number of uninsured, and through a variety of different tactics, which we'll talk about a little bit more in depth. But initially, back to 2010, the uninsured rates were about 16.3% nationally, which is about 50 million people. And here in Delaware, it was 10.7%, so about 100,000 people. And the rate in Delaware was much lower than the national level, in large part attributable to that the federal poverty level was set at 100% of, the Medicaid eligibility was set at 100% of the federal poverty level, and childless adults had a way to qualify, which in the rest of the country wasn't necessarily the case because it was left to a state-by-state decision making. So several provisions of the ACA became effective January 1st, 2014. One was Medicaid expansion to 138% of the federal poverty level. Next, that the marketplace exchanges for qualified health plans with income-based subsidies went live, and in Delaware there were 21 QHPs in the first year. And there was also an individual insurance mandate. And we're going to talk about each of these a little bit more in depth. So each state was given discretion to opt in or out of Medicaid expansions, which certainly impacted the rate of the coverage change that we saw in the first year. 26 states, including Delaware, opted to expand Medicaid coverage, which, as you know, was largely driven by political considerations within each state. States also had purview over their marketplace exchange implementation. They could either implement their own marketplace, which only 14 states did. They could do a federal and state collaboration marketplace, which Delaware actually did, one of 7 states. Or they could just let healthcare.gov be the only portal through which patients or individuals could access new enrollment, and that was 29 states just allowed the federal exchange for their residents. And then the last piece of this was that the individual mandate rolled out as well that required minimal essential coverage, so basically the bronze plan, if you've heard that in the news, or individuals would face a tax penalty. So when I say almost all, that means very well-defined exclusions such as incarceration. So really everyone was required to get insurance enrollment. And this was the only provision actually that was mandatory and not really at the state's direction. The first two were more at the state's discretion as to how to direct those things. So within Delaware, the Affordable Care Act implementation was led by the Delaware Healthcare Commission. And they launched this website here at the bottom that I have a snapshot of called Choose Health Delaware. And Choose Health Delaware also had a variety of marketing techniques to try to appeal to newly eligible individuals to help them connect to healthcare services as well. And one of the main focuses of the enrollment assistance during the first year was this funding of the Marketplace Guide program. And that's where we're going to get more into depth with the project that I'm working on. So the Healthcare Commission provided over $5 million for one-to-one enrollment guidance through Marketplace Guides. MPGs is how I'll be abbreviating it for the rest of the talk here. And Christiana was one of the recipients of that grant with about over $500,000 to fund. So the goal with the Marketplace Guides was to help individuals to understand what options were available to them and to receive enrollment guidance. Nationally, there was a similar program that had rolled out, what was called the Navigator program. And both navigators and MPGs had to go through extensive training and background checks and an examination to become certified in order to become an MPG. So just so you have a sense of the rigor that was involved with helping to create this program. So switching gears a little bit, who were the uninsured in Delaware pre-ACA? They were more likely than the state average to be male. You can see 48% of the state versus 53% of the uninsured. Be between the ages of 18 and 64. So again, 62% of the state population, but 82% of the uninsured. Be of Hispanic origin, 10% out of state, or 10% of the state, and 26% of the uninsured. Be non-citizens, which the ACA actually did not cover, but it's still important to acknowledge. And so you can see that it wasn't a homogeneous group. So the potential impact of the ACA did vary based on the individual's income and demographics. And the Kaiser Family Foundation put a nice pie chart together here to understand what different buckets people fell into with potential coverage. So you have Medicaid eligible adults are at the top at 28%, and we'll just focus on the adults for the sake of this analysis. And then you had on the left-hand side, eligible for tax credits, unsubsidized marketplace, or employer-sponsored insurance, which was another about 40%. And then at the top here, ineligible because of their immigration status. So just to help you get a sense of who actually could be enrolled and affected by this. So the initial enrollment year fell a little short of expectations. For 2014, less than a quarter of the pre-ACA uninsured total actually sought enrollment. So about 8,300 individuals joined Medicaid, which was 50% of the total that could have qualified. About 14,000 enrolled in a QHP via the marketplace, which was about 30% of the estimated total. And MPG assisted enrollment accounted for about 10% of all the enrollments in Delaware. Nationally, the uninsured rate decreased about 36% in Medicaid eligible states, or expansion states rather, and 30% overall to about 13% for the first year. And good news for the actually updated statistics, the uptake has really increased in the last 2 years. So the uninsured population through this last enrollment cycle decreased by 30% to now 7.4%. And Medicaid enrollment has grown by 6%, and just to give you a sense of how that reflects the state population, that's about 20%. 85% of the eligible individuals for a QHP enrolled, of which about 82% received financial assistance through the tax credit method. And then nationally, the non-elderly uninsured rate decreased by 37%, down to 10.5%. And you can really see in the last 3 years that there was that strong drop-off, whereas historically it had been pretty steady around the 16 to 18% range. And so to drop in that past couple of years, it really shows that it's attributable to the Affordable Care Act. So starting to get into the project that I'm working on, some of the key assumptions to just put out there so that you're aware of the structure that we're viewing this through is that many factors influence how patients access healthcare services. So I'll share with you my conceptual model. Experts predicted a large initial demand for healthcare services, particularly emergency department use, in spite of the market efforts to drive healthcare utilization to the lowest cost environment. And health insurance and the ability to pay is a requirement for accessing care, other than for emergencies. And so the uninsured are likely to have limited experience with accessing the continuum of healthcare settings. So the conceptual framework that I'm working from is adapted from a Day and Anderson's framework of the study to access to medical care. And I'm not going to get into all the details of this, but I wanted to just kind of bring this up to show that it's sort of a feedback loop in terms of when a patient has an experience with the system, that experience then drives their future access. And there are also characteristics of the health system itself, such as accessibility and capacity, that also influence. So all these factors interact with one another to actually influence where patients access care. So out of this, what I'd like you to take away is that the healthcare environment is complex and predicting utilization is complicated because of those individual factors. So nationally, the Oregon Medicaid expansion and ED utilization in 2008 from the expansion of Medicaid in that state, they've yielded some results that are probably going to be similar to what we would see nationally after the expansion of the ACA. Researchers found increases in ED visits, including an increase across a broad range of visit types for conditions that could be treatable in a primary care setting, and ED use stayed high 2 years after individuals gained coverage, even as they increased physician office visits. So overall utilization continued to be higher and not just rebalanced. On another note, in Maryland, this was actually pretty recently, that 5 Maryland hospitals in Montgomery County referred uninsured patients from the ED to local safety net clinics through a patient navigator program. And this isn't the federal navigator program for enrollment assistance, but a different local program that they had created. And the goal there was to connect patients to a medical home. And they found a significant reduction in subsequent ED visits among patients with chronic physical or behavioral conditions who had 2+ visits to the same primary care clinic. So suggesting that they had found a primary care source, and so that would redirect their use. But the key in this situation was that the individuals had someone who was intervening and helping to direct them and not just left to navigate the system on their own. So after this first year of the ACA rollout, the Kaiser Family Foundation surveyed 4,400 of the national navigator assister programs across the country. And 75% of these programs reported that a majority of consumers lacked the basic understanding of insurance in terms of understanding what a copay was, what a deductible meant. And 90% were contacted by consumers with post-enrollment questions. But this was completely out of the scope of what the navigator programs were intended to do. They were intended to provide enrollment assistance and not necessarily to provide ongoing support once the individuals were enrolled into coverage. So CMS also recognized this and launched an initiative called Coverage to Care midway through 2014 to try to help the newly insured understand their benefits and try to connect to primary care and preventive services. I'm not sure that there's been any data on how effective this has been. It's a 58-page booklet. I imagine that would be a little bit dense for individuals new to healthcare to navigate through, and they also launched a website. So I just bring this up to show that there was national recognition that that getting insurance doesn't necessarily help an individual to change their behavior or even to access care in the most appropriate setting reflective of their condition. And then the other aspect that I want to highlight before we really jump into the specifics of this program, and thanks to Brian for highlighting this article for me, is that the inequality in medical spending over time has increased by income. It's just one of those, another one of the facets of our society, again, where there's now an income disparity, where the people at the highest income level, the line in yellow, are now able to access and consume more health care than the lowest income quintile, which is the darker red line that's decreased and kind of leveled off and merged with the orange line there. So in the past, there had been a lot more equity in terms of accessing care, but now it's showing that as income increases, we're more able to access healthcare services than those that are in the lowest income bracket. So keeping all these things in mind, I'm going to go back and incorporate these, the literature review to the program and how we are approaching the analysis of it. So here at Christiana, enrollment really focused on Newcastle County residents in existing Christiana sites. And you can see at the bottom here for this upcoming enrollment year, some of the flyers that have been produced. There are tables. The team has really made an effort to enroll as many patients as possible and be effective as possible. In addition, the program here exceeds the state scopes for MPGs. Not only do they assist with marketplace enrollment, but the goal really is to assist individuals with referrals into the health system as need dictates, so to try to get people connected to primary care. And that really has the potential to impact utilization, which in other settings, if there's not someone to direct that kind of involvement, it's lacking. So it's the MPG program was built on the infrastructure of the health coaches program, which grew from 2 health coaches to 12 MPGs, and now it's actually called the Health Guides program. But it had demonstrated success in the past of directing over 2,500 patients to a medical home and showed some results with some improved outcome results for diabetic and hypertensive patients. So it's built from a strong infrastructure. And this is a snapshot of the web-based intake form that for each encounter with an individual to provide enrollment assistance that the MPGs would fill out, and this is where we started to form our data set initially. And so in thinking about the patient population that would be recruited into the MPG program, they have barriers that go beyond just insurance status, that include poverty, housing, safety, transportation, health literacy, and just the ability to navigate a complex healthcare system. So this is also a trivial thank you to Brian here for a recent presentation that he gave that in this slide really highlights around Wilmington Hospital the ethnic and racial segregation that is inherent in that area. The green dots are African American residents, the orange dots are Hispanic residents, and then the white dots are Caucasian. So you can see that around the Wilmington Hospital that there's a really high concentration of minority residents. And this map also reflects the community need that group has. So in terms of the color scheme here, the highest need is in red down to the lowest need in blue. And the highest need represents income, cultural, education, and insurance and housing barriers that these individuals often face. So in thinking about who is going to be impacted by this program, there's really a potential to reach the individuals who need services the most. So the significance of the Christiana MPG program really is that, first of all, thinking about the resource utilization, the substantial funding for outreach efforts and coverage expansion, both nationally and at the local level, came from the state and federal government, from Christiana. So we really want to know that those funds had an impact, both on enrollment support and then beyond that scope for the Christiana MPG population. We know that new insurance coverage was expected to increase utilization and that the newly insured may not be familiar with the continuum of services. So the referrals that the Christiana MPGs made really had the potential to impact how individuals, and particularly those from those underserved communities, access and utilize healthcare resources, particularly in comparison to other markets where they may not have had that same kind of assistance. So my primary research questions that we're going to explore are: who was exposed to the MPG assistance, and does that exposure impact their utilization of healthcare services, both the quantity and the type as indicated by the location of services? So we started out with the MPG Intake database, which had limited demographic information on about 4,000 unique patients. And thank you to the Value Institute who was able to map that database to the Christiana data warehouse. There was about a 65% match with expected 98% accuracy. So we had about 2,700 individuals that we were working with in the sample. And to just give you a sense, if you've not worked with the Institute before, as to how they're able to accomplish this, they had a method that they've tried and tested that has an exact match for last name, first name, and the first four digits of an address in order to map the two databases together. And the importance of this is that without that mapping, we wouldn't be able to really have any outcomes on the MPG group as far as their enrollment status, because if you remember back to 2014, actually, with the issues with healthcare.gov, there was actually a delay in a lot of people being able to enroll. So the initial intake with the MPGs may not have even resulted in enrollment at that time. So when individuals were able to utilize services within Christiana, that's how we ascertained what type of insurance coverage that they had at the time of the service that they accessed. So that will become clear as we go along. So who's in the data set and the analysis that we're doing? The criteria for inclusion was utilization within Christiana in 2012 and 2014, so pre and post ACA, and it could be any combination of emergency, inpatient, or outpatient utilization, also within the 18 to 64 age group between those 2 years. So our study group is the MPG group, and from the 2,700, we're down to about 952 that met that criteria listed above. And I'm highlighting here because one of the first findings that we had was that there really, I came into it thinking that a lot of these people would be uninsured initially, and that wasn't necessarily the case in holding steady across the 2 years. So after a lot of iterations, which I won't go into the gory details of right now, unless anyone's interested at the end, we identified these groups by insurance status in the 2 years. So in the Medicaid group, this means that a person had Medicaid in 2012 and 2014, or that they were uninsured in 2012 and 2014. And mixed insurance means that they could have been, that they moved in and out of insurance. And so in terms of the comparison group, we were able to find non-MPG assisted patients that had the same insurance makeup, other than the mixed insurance group, which we don't have a comparison group. And so the analysis is going to focus on the Medicaid and the uninsured in the subsequent slides. So to just give you an overview of the demographics in each of the groups, they were actually pretty similar in the Medicaid group and in the uninsured group in both of the two MPG assisted and non-MPG assisted groups. But interestingly, overall, there were significant differences. But within the groups themselves, the statistically significant differences I've highlighted in red. So the Medicaid MPG assisted group tended to be a little older, and the MPG-assisted uninsured group tended to be a little bit more male and a little bit more ethnically diverse than the non-MPG group. But again, I'll draw your attention to the numbers at the top that in the MPG-assisted uninsured group, there's only 44, so even a couple of changes would have made a difference in that group. So we're dealing with very similar groups within the Medicaid 2 groups and the uninsured 2 groups. So the other piece of course, what impacts utilization is someone's health status. And so it was important to identify in the data set if people had chronic conditions. So bear with me here. There's a lot of acronyms that I'm going to walk through, and I'll to try to explain as to how I was able to pull out the chronic condition indicators that we'll also be considering in our models. So the Agency for Healthcare Research and Quality has a healthcare cost and utilization project that they provide classification software for ICD-9 codes, basically, that helps to catalog over 14,000 diagnosis codes into clinically meaningful categories, such as body system or whether something is a chronic disease. And so I took the diagnosis data from the data warehouse by patient encounter and mapped it to these classifications. And then I identified the top 15 chronic ICD-9 codes, which was a percent of the total encounters, and linked it to the unique patient ID if it was ever documented. So if someone had 3 ED visits and one of them had shown that someone had asthma, that would then become linked to that patient's identifier in the subsequent analysis. So I'm not going to go necessarily through the percentages of all of these, but I just wanted to go through and let you know as far as the chronic conditions that we're considering. And again, between the two groups in Medicaid and the uninsured group, the non-MPG and the MPG groups were not significantly different in most of these chronic conditions, although overall in the sample there were significant differences. So the things that we looked at were being overweight or obese, tobacco use, mental disorders, hypertension, diabetes, asthma, neoplasms, a combined variable for hypertension, diabetes, or asthma, and then another chronic condition field to simplify the model, which includes the following 8. MS, disorders of lipid metabolism, HIV, chronic airway obstruction, pain, heart failure, osteoarthritis, which there is a significant difference here, but again, in the MPG-assisted uninsured group, which is a small group, chronic kidney disease, renal dialysis. And so if at the end anyone wants to come back, we can look at the percentages of those and have more of a discussion about it, but just suffice so that you know as far as what's being incorporated in these future models, and that there are not significant differences between the two study groups within each of the insurance categories. So to get into the utilization variables, the dependent variable in the models is the utilization by category in 2014. So how did the insurance status, the MPG involvement, all these other factors come into play for utilization within the calendar year of 2014 in the emergency, outpatient, and inpatient settings? And this is looking at over 32,000 encounters for a little over 4,000 patients, with the exception that we did exclude outliers that were greater than 4 standard deviations above the average of the combined utilization in each of these categories. And I have a cut points here, which ended up being about 2.5% of the study population. And I think that's something at the end that if we wanted to return to and look at these high utilizers, that would be maybe a future area of study. I know that there's a similar project in Milwaukee that looked at high utilizing patients in the ED. We actually had one patient who had over 200 visits in a single year. So it's certainly an area of focus, but one we haven't explored yet. So I'm going to go through these one by one. The MPG Medicaid group had an average of 2 visits in 2014 and 1.6 visits up from 1.6 visits in 2012, which was an increase in their utilization of the emergency room, and then in a paired t-test that was not statistically significant. The non-MPG assisted Medicaid group had about 1.5 visits in each of those years with no change. And looking at the change comparing those two changes, so a difference in differences model between the two groups, even though the MPG group had about a 0.6 increase, and it was not statistically significant, the change that the MPG group had in the number of visits compared to the non-MPG group. Though materially it may be something of interest to note that the MPG group did have a higher utilization. And the same goes for the uninsured group. The MPG group had an increase in their ED visits. The non-MPG assisted group had a decrease, but the comparing the two changes between the two groups was not statistically significant. So in the outpatient world, there was an increase for MPG visits by about 1/2 of the visit. There was an increase for Medicaid patients, but at a much lower rate of about 0.018. But that difference between the two was not statistically significant. For the uninsured, there was actually a decrease in both groups, though less in the MPG uninsured group, but that change also between the two groups was not statistically significant. And in inpatient utilization, there was a decrease across the board, which was statistically significant for the inpatient group, but I think that it's difficult to say that it's attributable just to anything in the data set besides just knowing in the marketplace that there are a lot of changes in Medicare regulations at the time as far as for admission criteria, et cetera. So that would be another area of possible study, but I think that the outpatient and ED utilization are more of a focus and more of a priority in our analysis. So I won't get too deep into the statistical model here unless anyone wants to go back to it, but I did run a negative binomial regression because the outcome is a count variable. And the incident rate ratio in the MPG variable was statistically significant for the Medicaid comparison groups. And that means that the Medicaid-assisted patients were, holding all other variables constant, more likely to access outpatient services and have ED visits. And you can see with the asterisks when what other independent variables were statistically significant. So age was certainly a variable. Ethnicity played a small role. And then the chronic conditions at the bottom here, you can see which ones factored in and did not. Similar for the uninsured group, statistically significant for the Medicaid, MPG assistance, and MPG-assisted uninsured patients were 4.2 times more likely to use outpatient services than the non-assisted patients. So I think if you're thinking in a broader social context, that's a good thing, that the MPGs may have had an impact on helping the neediest patients to get outpatient services, not just in the ED, although there was a higher propensity among the MPG-assisted patients to also have ED visits. So in terms of just understanding the data set a little bit more, one of the things I forgot to mention on here was that the utilization is limited to the Christiana system. So of course we got the utilization data from the data warehouse, but if a patient were to use care at, say, Westside or another emergency room or anywhere else, we wouldn't be able to reflect that here. So that is certainly a limitation of the study data that we have. About a third of the diagnosis information was missing just as an issue with the data warehouse mapping. But there were very few, less than 100 patients who had no diagnosis information listed. So there was also limited differentiation within the outpatient visit type, so this may be an area for us to explore more in the future, whereas the emergency and the inpatient were much more well-defined as to what those types of visits rolled up to. There was so the analysis is focused on the number of encounters in each of these categories rather than charges, because there are a lot of actually zero charge encounters that are a reflection of when patients already have charity care arrangements made, et cetera. So the comparability of charges across encounters and entities is somewhat limited without doing some more consideration of how to account for that. The changes in the MPG insurance group status beyond the uninsured and Medicaid groups, we would really have to come up with control groups to be able to consider how the MPG involvement impacted utilization and not just the insurance variable did. So that's a future consideration as well, and that's still 780 patients that were not included in this in-depth analysis. So as far as next steps, we have certainly other areas that we could explore. So patient geographic origin is certainly one, so the distance to care and the zip code of origin as an indicator of the socioeconomic status of a patient. We could certainly explore some of the chronic disease factors and stratify by those in depth if that were an area of interest. We could also look at, there's a recurring visit type that I didn't really highlight in here that could also be associated with certain chronic conditions that we could explore. I mentioned about the outpatient visit type, about exploring that in a little bit more depth if we had some more detailed data for that. And then there's also a recent Delaware household survey that went into some depth with asking individuals to report about their healthcare utilization and their health status, and so there certainly could be a linkage between the two based on zip code. And then I look to you as more acquainted with the Christiana patient population than I myself am, as far as if there are areas of strength that you think would be interesting to explore among this group to see how certain other programs may fare among this population. And so with that, I open up for questions, and I thank you for having me. Omar.
Yeah, thank you very much for that. So the data you showed around the ED utilization, which increased, is congruent with the work we've seen out of Washington State and other places, which showed that access to insurance and access to facilitated insurance does increase ED utilization, at least in the short term. The outpatient data which you showed, I think, was very powerful, and that's the flip side of utilization is access. That's actually the good thing, as you said. We want folks to access outpatient services. Have you come across data from other settings that suggest that access to insurance and facilitated access improves outpatient care or more appointments like you showed here, or is this the first time we're seeing something like this from the national data?
So the Maryland data that I mentioned about, where those were uninsured patients, but having an assister connect them to outpatient services, and when they actually continue to go to those services, that did have an impact. Otherwise, nothing else comes to mind where I've seen in an outpatient setting. A lot of work is really focused on ED utilization, and maybe in the next couple of months or or 6 months, as the ACA has continued to take effect, we'll see some more outcomes that could reflect that.
Well, it's really, really fabulous. I really enjoyed it. I learned a ton. I wonder your thoughts on best approaches in design, because in looking at policy implementation in effect, randomized trials are effectively going to be impossible, and that means very hard to control, and you're limited to either some kind of control group or before and after, or can you find instrumental variables? What are your thoughts on how we can try and understand causal relationships between policy and outcomes? What are our best approaches?
Yeah, I definitely think that this is reflective of a program evaluation versus, like you said, more of a randomized approach. And so in thinking about management projects from the outset, if you could design the intake forms to be more reflective of the factors that you think will impact outcomes, I think that would really go a long way to help. And I think with the Health Guides program and talking with Kathy and Carla about how the program has changed, there is more now recording of other subsequent encounters and what recommendations are made to the patients. Because I think what you're suggesting is that the initial visit with the MPG can be somewhat limited potentially if that's the only data point that you have as to how that person impacted the outcomes. Whereas I think if these programs are more focused longitudinally with forming relationships with patients and have follow-up and have recorded follow-up so that you can actually track how the assistance that you're providing then yields those changes to behavior, I think that having that more proactive approach to what data fields that you think will have the most impact would really go a long way towards showing a more of a causal relationship.
So there's nothing like good design in the beginning. When you come at it at the end, it's very difficult. The other question along those lines, your thoughts is, in things like this, you're always going to have tons of missing data. You want to minimize it, but I just want your thoughts, because we can't assume that data are missing at random.
Right. So I'm not sure that actually one of the things that we plan to do is go back and do a sensitivity analysis to look at the missingness of across the data sets, looking at people who have more than 50% of their diagnosis codes versus less than that. And I just haven't had a chance to do that yet. But I think that the more interesting piece of missingness would be to understand full utilization, or have a fuller picture of utilization by using something like DIN or using Medicaid claims data, where you could really see across a patient their full utilization rather than just at Christiana, because we certainly don't know how much that represents of how much a patient has accessed care. I have run some models that look at utilization limited to if someone's had greater than 0 visits, greater than 1 visit, and it really hasn't impacted the outcomes of what I've looked at in terms of the coefficients in my models, but presumably it's just unknown at this point what really the full utilization contingent would look like across this patient population.
I'm curious if you know anything about the mixed insurance population, whether any subset of that might include Medicare, SSI, which in that age range is usually highly representative of mental illness.
So yes, there definitely is Medicare represented within that group, and I think it's about 200 of those patients who had Medicare in both years, because that's how I was really trying to group. But I did not look at their diagnosis data, so I cannot comment as to the prevalence in that group.
Did you look at the interactions, for example, between gender and MPG or something like that, to see whether there was a difference in the number of...
Not at this point, but that's a good suggestion to just try to figure that aspect out. Mm-hmm.
Well, fabulous.
Thank you very much.